Welcome to another episode of My Weird Prompts, an AI-generated podcast featuring the random prompts of Daniel Rosehill as answered by a revolving cast of friendly AI characters. Join us for deep dives into AI, technology, and whatever other random thing Daniel finds fascinating today. Subscribe on Spotify or your favorite podcatcher. Now, today's episode.
This episode was generated using artificial intelligence. Please verify facts.
Hey, Herman and Corin. We talked about how one of the skill of triage when we did our series looking at people who do really interesting jobs, and I guess it fits so well into our recent conversations about preparedness, and even in the context of fantastic multi-monitor workstations, the dispatch centers that are the unsung heroes of the emergency services world and actually send out the police units, firefighting and paramedics to a scene. And of course, speed is the name of the game in that environment. One thing that I'd love to actually chat about, because it dovetails nicely here and it touches upon another important point, which is standardization, is medical coding. So we've heard for a while about niche jobs in the world of medical coding, people who are experts at using a precise coding system in order to identify with a standardized identifier either a suspected type of medical event or an actual diagnosis. And I've never really, for I guess the obvious reason that I don't work in this field, known much about it beyond that. But I do have, of course, it wouldn't be me if I didn't, some inkling of curiosity here. I guess I'm curious to know whether this is a standardized system, because so much of what we see here in Israel ends up being really, really bespoke. And we've talked about this in the context of the cost of living in Israel and to what extent standardization or the opposite of it, local only standardization, can be a real barrier to entry and cause of unnecessary inefficiency. And in this context of medical coding, that's really what I'm asking. Is there a standardized, globalized, international system? Or does it vary according to health systems and maybe the type of diseases that are being encountered more among a certain population? So if I go in the door of emergency room here or urgent care room and I have an asthma exacerbation that requires treatment with Ventolin, and then I'm discharged, which of those events, if I come in, has a specific identifiable code that's going to be the same whether I walk into a clinic in Sao Paulo or in Jerusalem? And I think one thing that strikes me that would be very useful here is being able to provide consistent information across languages before the era of really easy machine translation and very effective machine translation. Perhaps that's one of the reasons. And I'm just curious how that actually fits into the broader picture of electronic medical records, EMRs, this information, how it can be used. And for drugs as well, I mentioned Ventolin for a reason. Is there a globalized, standardized system of trade names vary, of course, across jurisdictions, but the active ingredients and the dosages are the same, usually. Some minor differences in formulation. So to what extent is this data standardized and interconnected in today's world? Over to you two.
Hey Herman, you ever think about how much invisible infrastructure is supporting us every time we interact with a modern system? I mean, we talk about the internet or the power grid, but there is this whole other layer of data that basically translates our physical reality into something a computer can understand. It is like we are living in a world of objects, but the machines are living in a world of labels.
Oh, absolutely. Herman Poppleberry here, and I have to say, that is a rabbit hole I have spent far too many late nights exploring. It is one of those things where the more you look at it, the more you realize that the world is essentially held together by spreadsheets and classification systems that most people never even hear about. We like to think of medicine as this very human, hands-on art, but behind every stethoscope is a database waiting to be fed.
Well, today's prompt from Daniel is right in that wheelhouse. He wants to dig into medical coding. Specifically, he is curious about how standardized these systems really are. If you show up at a hospital in Sao Paulo with an asthma attack, and then a year later you're in an emergency room here in Jerusalem for the same thing, is there a universal language that describes what happened to you?
That is a fantastic question because it touches on the tension between the global nature of science and the very local, fragmented nature of healthcare systems. And the answer is a classic yes and no situation. On one hand, we have some of the most sophisticated international standards in existence. On the other hand, the way those standards are actually used can vary wildly depending on who is paying the bill and what country you are in. It is February of 2026, and while we have made massive strides in the last 5 years, the Tower of Babel problem in medical data is still very much a reality.
Let's start with the big one. If I have asthma, there has to be a code for that, right? I have heard of the ICD codes. Is that the gold standard?
It really is. The International Classification of Diseases, or ICD, is the backbone of global health data. It is managed by the World Health Organization, or WHO. As of right now, in early 2026, we are largely through the massive global transition from ICD-10 to ICD-11. But to answer Daniel's question directly, yes, if you have an acute asthma exacerbation, there is a specific code for that in the ICD system. In the older ICD-10, you were looking at the J45 category. In ICD-11, which is the current international standard, it has been refined even further.
So J45 would be recognized in Brazil and in Israel?
Exactly. The core of the ICD is designed to be a universal language for mortality and morbidity. It started way back in the late 19th century, believe it or not. It was originally called the International List of Causes of Death, often attributed to Jacques Bertillon. The idea was that if we want to understand how people are dying around the world, we need to make sure we are all calling a heart attack a heart attack. If Brazil calls it cardiac failure and Israel calls it myocardial infarction, the global statistics are useless.
That makes sense for tracking pandemics or global health trends. If the WHO wants to know if asthma rates are rising globally, they need everyone to use the same label. But Daniel also asked about how this fits into the broader picture of electronic medical records and whether it is truly interconnected. If the code is the same, does the data actually move?
That is where the friction starts. You see, the ICD was designed for statistics and epidemiology. It was not originally designed for the day-to-day clinical management of a patient or for the incredibly complex world of insurance billing. So, while the what of your diagnosis might be standardized, the how of your treatment is where things get messy. In Sao Paulo, you might be treated under the SUS, the Sistema Único de Saúde, which is Brazil's massive unified health system. They use ICD codes for reporting, but their internal billing and resource allocation might look very different from a private hospital in Jerusalem or one of the Israeli health maintenance organizations like Clalit or Maccabi.
Right, because a hospital in Sao Paulo might use the ICD code for asthma, but they might have a completely different way of coding the actual nebulizer treatment they gave you, or the specific type of steroid shot you received.
Precisely. And this is where we have to talk about clinical modifications. In the United States, for example, they have their own special version called ICD-10CM. It is basically the international code on steroids. They took the base codes and added tens of thousands of subcategories to satisfy the demands of the American insurance industry. So, while a doctor in Jerusalem might just see asthma, an American coder might be looking for a code that specifies if it is exercise-induced, or if it is a chronic obstructive pulmonary disease overlap, and whether it was an initial encounter or a follow-up. We are talking about a jump from about 14,000 codes in the base ICD to over 70,000 in the US version.
It is like everyone is speaking the same rude language, but some people are using a very technical dialect that includes details about the color of the patient's shoes.
That is actually a pretty good way to put it. And it creates this massive burden for medical coders. This is a huge profession that people don't often think about. These are professionals who spend their entire day reading through a doctor's notes and translating those human sentences into these alphanumeric codes. If the doctor writes, patient was wheezing and unresponsive to inhaler, The coder has to decide which specific code in the 10,000 plus options best represents that clinical reality. By 2026, a lot of this is being assisted by AI, but the complexity remains.
I imagine that is where a lot of the errors creep in. If it is that complex, how can we ever expect two different systems to talk to each other perfectly?
Well, that brings us to the second part of Daniel's prompt about drugs and active ingredients. He pointed out that while trade names like Ventolin might change, the active ingredient, like salbutamol or albuterol, is the same. You would think that would be the easy part to standardize, right? Chemistry doesn't care about borders.
You would think so. A molecule is a molecule whether you are in the Amazon or the Galilee.
You would be surprised. There is a system called the Anatomical Therapeutic Chemical Classification System, or ATC. It is also managed by a WHO collaborating center in Oslo. It classifies drugs based on the organ or system they act on and their chemical, pharmacological, and therapeutic properties. It is a beautiful 5-level hierarchical system. For example, salbutamol has the ATC code R03AC02. The R stands for Respiratory System 03 for drugs for obstructive airway diseases and so on.
So if the ATC code is universal, why is there still a problem?
Because of identifiers. Think of it like a barcode. Every country has its own regulatory agency that assigns specific identification numbers to the drugs sold in that country. In the United States, you have the National Drug Code, or NDC. In Brazil, you have the ANVISA registration numbers. In Israel, the Ministry of Health has its own registry. So, even if the ATC code for the active ingredient is the same, the actual digital object representing that box of medicine in the hospital's computer is often local.
So if the computer in Sao Paulo is looking for a specific Brazilian drug ID, and the record arrives from Jerusalem with an Israeli drug ID, the computer might just throw up its hands and say, "I don't know what this is."
Exactly. It is like trying to use a European power plug in an American outlet without an adapter. The electricity is the same, but the interface doesn't match. This is the big challenge for electronic medical records, or EMRs. We have these massive silos of data. This is why a new international standard called IDMP, or Identification of Medicinal Products, is so important. It is a set of 5 ISO standards that are finally being implemented globally to create a truly unique global identifier for every drug product, but we are still in the middle of that rollout.
So, is there an adapter being built? I have heard about things like SNOMED. Does that help?
Now you are talking my language. SNOMED CT, which stands for Systematized Nomenclature of Medicine Clinical Terms, is basically the most comprehensive multilingual clinical terminology in the world. If ICD is the table of contents for a book of diseases, SNOMED is the entire dictionary of every medical concept imaginable. It covers everything from symptoms to anatomy to social context. It has over 350,000 active concepts.
That sounds like it would solve the problem. Why isn't that just the universal standard everyone uses for everything?
Because it is incredibly dense and complex. SNOMED is a polyhierarchy, meaning one concept can have multiple parents. For example, pneumonia is a type of infectious disease, but also a type of lung disease. Implementing it is a massive technical and financial undertaking. Most hospitals are still struggling to get their basic systems to talk to each other, let alone implementing a system that is as complex as a human brain. However, many countries, including Israel and Brazil, have adopted SNOMED as their national standard for clinical terminology, even if the billing still happens in ICD.
It seems like we are in this weird middle ground where the science is global, but the administration is intensely local. It reminds me of the early days of the internet, when different networks couldn't talk to each other before TCP/IP became the standard.
That is a perfect analogy, Korn. We are currently in the post-standardization but pre-interoperability era. There is a new standard that has really taken over in the last few years called FHIR, which stands for Fast Healthcare Interoperability Resources. It is pronounced like fire. It is designed to be the modern web-like way for health systems to exchange data. Instead of sending a giant, messy PDF of your medical history, it breaks the data down into small, standardized resources, like patient, observation, and medication.
So, if FHIR becomes the norm, the system in Jerusalem could just request the medication resource from the system in Sao Paulo, and they would both know exactly what language they are speaking.
That is the goal. In fact, by 2026, many international health exchanges are using FHIR to power what we call the International Patient Summary, or IPS. The IPS is a standardized set of health data allergies, medications, problems that is designed to be shared across borders. If you have an IPS-compatible app on your phone, that doctor in Jerusalem can scan a code and instantly see your asthma history from Sao Paulo, translated into the local terminology.
That feels like a huge win for the patient. But Daniel also asked about whether these systems vary based on specific populations. Are there codes that only exist in certain parts of the world?
Oh, definitely. This is one of the most interesting parts of ICD-11. They significantly expanded the sections for traditional medicine. This was a big move to include traditional Chinese medicine, for example, into the global statistical framework. It allows researchers to track the use and outcomes of these treatments alongside Western medicine. There are also codes for specific conditions that are endemic to certain regions. A clinic in the Amazon is going to be using a lot of codes for tropical parasitic diseases that a clinic in rural Norway might never touch.
It sounds like the medical coder is almost like a translator or a diplomat between the messy reality of a human body and the rigid logic of a database.
I love that, a diplomat for data, and it is a high-stakes job. If a coder gets the code wrong, the hospital doesn't get paid, or worse, the patient's record becomes a mess of misinformation. There is actually a famous list of weird ICD-10 codes that people like to laugh at, which were designed to capture every possible injury for safety statistics. Things like V91.07XA, which is burn due to water skis on fire, initial encounter.
Wait, that is a real code.
It is a real code. There is also W61.62XA, which is struck by a duck, initial encounter. And my personal favorite, Z63.1, which is problems in relationship with in-laws.
I mean, I guess if it happens, you need a code for it. But it does feel a bit like they're trying to account for every possible permutation of human misfortune.
They are. Because if you want to do high-level safety research, you need to know exactly how people are getting hurt. If 1,000 people are getting struck by ducks every year, maybe we need a public awareness campaign about aggressive waterfowl. You can't know that if everyone just codes it as animal encounter. The granularity is what allows for the insight.
But back to Daniel's example. If I am the patient, and I am sitting in that ER in Jerusalem, and I tell the doctor I was treated for asthma in Sao Paulo, what is the best case scenario for my data right now in 2026?
Right now, the best case scenario is that you are using an international patient summary compatible digital health wallet. Most modern smartphones now have this built in. When you were treated in Sao Paulo, that hospital, if it is part of the global interoperability network, would have pushed a summary to your device. That summary contains the ATC codes for your meds and the SNOMED codes for your diagnosis. When you get to Jerusalem, you authorize the ER to pull that summary. The doctor screen then populates with your history, already translated into Hebrew or English.
That feels like the future we were promised. But how common is that actually?
We are at about 40 to 50% global adoption for that level of seamlessness in major urban centers. If you are in a rural area or a country with less digital infrastructure, you are still back to the old ways, carrying a paper printout or trying to remember the name of the inhaler you used. This is why we always talk about personal preparedness. You cannot rely on the system to be perfectly interconnected yet.
That brings us to the practical takeaways. If I am a listener and I want to be prepared, like we talked about in our triage and preparedness episodes, what should I be doing? If I can't rely on the standardized, globalized, international system to work perfectly, how do I bridge that gap?
This is where you become your own data diplomat. First, always know your active ingredients. Don't just say you take Ventolin, say you take salbutamol. That is the universal language. If you have a chronic condition, keep a list of the ICD codes for your primary diagnoses. You can usually find these on your discharge papers or billing statements. If you show a doctor J45.9, they will know exactly what you mean, regardless of what language they speak.
That is a great tip. It is like having a medical passport. Instead of trying to describe your symptoms in a foreign language, you just point to the universal code.
Exactly, and the same goes for lab results. There is another standard called LOINC, which stands for Logical Observation Identifiers, Names and Codes. It is the universal language for lab tests. If you have your blood sugar or cholesterol results, they will have a LOINC code. For example, a common glucose test is LOINC code 2339-0. If you have that, any doctor in the world can interpret the results without worrying about whether the units or the naming conventions are different.
It's interesting that we have all these amazing tools: ICD, SNOMED, ATC, LOINC. But the missing piece is the glue that holds them all together and makes them accessible to the patient and the provider in real time.
The glue is what we're building right now with FHIR and the push for open APIs in healthcare. In the United States, the 21st Century Cures Act really kicked this off, and other countries have followed suit. It basically mandates that hospitals must give patients access to their own data in a machine-readable format. This is huge. It means you can use an app of your choice to pull your data from the hospital's silo and carry it with you.
That feels like the real aha moment. The standardization isn't just for the bureaucrats and the insurance companies. It is the key to patient empowerment. If the data is standardized, it becomes portable. And if it is portable, it becomes much more useful.
Exactly. Imagine a world where you land in Sao Paulo. You get a notification on your phone that says, "Hey, we see you are near a hospital and we have your emergency medical profile ready to share if you need it." The phone could translate your Israeli records into the local Brazilian standards on the fly because the underlying codes are the same. We are very close to this being the standard of care globally.
We are getting there, but it sounds like we are still in that messy transition phase. It makes me think about the role of artificial intelligence in all of this. Surely AI is the ultimate medical coder now.
Oh, by 2026, AI has completely transformed the back office of medicine. We have ambient scribing now, where an AI listens to the conversation between the doctor and the patient and automatically generates the notes and the codes. It is much faster than a human, and it can cross-reference those 70,000 subcategories in milliseconds. But, and this is a big but, it still needs a human in the loop for the weird stuff.
I can't imagine an A. I trying to figure out if someone was struck by a duck versus struck by a goose without some context.
You hit the nail on the head. The nuance of human experience is hard to code. If a patient says they feel heavy-hearted, does that mean they are depressed, or are they literally feeling chest pressure from a cardiac event? An AI might struggle with that metaphor, but a human doctor and a skilled coder understand the context. We are seeing a new role emerge, the clinical data auditor, who oversees the AI to make sure the translation from human life to computer code is accurate.
This really brings us back to the idea that medical coding is this bridge between the subjective experience of being a patient and the objective need for data. It is a fascinating hidden world.
It really is. And to Daniel's point about drugs, the IDMP standard I mentioned is the final frontier. It is a massive project involving regulators from the US, the EU, Japan, and beyond. They are trying to create a single global ID for every single drug product on Earth. It is a Herculean effort because of the sheer number of generic manufacturers and different formulations. But the payoff is huge. If we had a global drug ID, we could track drug shortages in real time. We could identify counterfeit medications much more easily. And most importantly, we could prevent those lost in translation errors in the emergency room.
It's like we are building a digital version of the Library of Alexandria for human health. Every disease, every treatment, every drug, all catalogued and cross-referenced.
That is a beautiful image, Korn. And just like the original library, the challenge is making sure everyone has access to it and can understand it. We have the alphabet, those are the standards like ICD, but we are still writing the grammar rules for how the whole system talks to itself. The good news is that the grammar is getting better every day.
It makes me wonder about the future of this podcast, too. We are using these prompts to explore the world. In a way, we are doing our own kind of coding. taking these big, complex ideas and trying to categorize them and make them understandable for our listeners.
Guilty as charged. We are the coders of My Weird Prompts. And speaking of the show, I think we have covered a lot of ground today. We went from the 19th century list of deaths to the future of AI-driven interoperability and the International Patient Summary.
We did. And I think the big takeaway for me is that while the system isn't perfectly interconnected yet, the standardization is much further along than I realized. The language exists, we just need the glue of better apps and international agreements to make it work for the person sitting in the ER.
Exactly. The foundation is there. Now we just need to build the house. And for the individual, the message is clear: own your data. Don't just be a passenger in the healthcare system, be the keeper of your own codes.
Well, I think that is a good place to wrap this one up. It has been a fascinating look into the invisible ink of the medical world.
It really has. I'm going to go double check my own ICD codes now, just in case I have any problems with in-laws that need documenting.
Good idea. And hey, to our listeners, if you have found this deep dive into the guts of healthcare data interesting, we would really appreciate it if you could leave us a review on your favorite podcast app. Whether it is Spotify, Apple Podcasts, or wherever you are listening, those reviews really do help other curious minds find the show.
They really do. It is the best way to help us grow and keep answering these fantastic prompts from people like Daniel.
And remember, you can find all our past episodes, including those ones on triage and preparedness we mentioned, at myweirdprompts.com. We have an RSS feed there for subscribers and a contact form if you want to send us your own thoughts or questions. You can also reach us directly at show@myweirdprompts.com.
We love hearing from you. Truly, every prompt is a new rabbit hole for us to explore.
This has been My Weird Prompts. I'm Korn.
And I'm Herman Poppleberry.
Thanks for joining us in the Library of Data today. We will talk to you next time.
Goodbye, everyone. Stay safe and keep your codes handy.
This episode was generated using Gemini Flash 3. Text-to-speech engine was Chatterbox.
Thanks for listening to another episode of My Weird Prompts, an AI-generated podcast featuring Daniel Rosehill's AI prompts, as answered by a revolving cast of friendly AI characters including me, Cornelius the Sloth. Subscribe on Spotify or visit myweirdprompts.com.